The Modern Pain Podcast is a proud member of the PT Podcast Network. Make sure you check out ptpodcastnetwork.com for other awesome PT-related podcasts. What is going on, everybody? Welcome back for another episode of the Modern Pain Podcast.
This is the Modern Pain Podcast with Mark Cardula.
This week, we're talking with somebody who I've had the privilege of getting to know here probably a few years ago when we had Peter on with Catherine Harmon in our master class when we were doing the Lifelong Learning Academy here at Modern Pain Care. Peter's a researcher, chiropractor. Just imagine that, PTs and chiropractors getting along. Back when I first got out of school, that was something that may not happen. But anyway, Peter, amazing researcher, somebody who's really had some positive impact on myself. So we get into a bit of his research on enactivism and the field of affordances he's worked with some colleagues on. We'll discuss some of the challenges we've had with some of these terminologies and discussions where how does this complex terminology around philosophy, phenomenology, and all these different things, where does that land with just the frontline clinician? It seems like a lot of difficulties in translating that, hence why we're having this podcast today. But also, we'll speak to some of the challenges in applying the biopsychosocial model, some of the difficulties of this linear application, this very compartmentalized application that really is due to some of the vagueness of Engel's theory that was proposed way back in the 70s. We'll speak to the 3 E's in the enactivist type approach, and then we'll discuss the field of affordances. It was a great discussion. We tried to bring it back to how did this help us clinically when we start reading some of this stuff that can get a little heady in the philosophical space, but something that I think worth at least having some exposure to, because it really not understanding some of the things that you implicitly just believe and theorize as truth in the world you function in the clinic and outside of the clinic, not knowing that to me limits your ability to better help unique people that don't fit those worldviews, that don't fit those unique philosophies that you may have, unbeknownst to yourself, really be rigidly operating under. So some of the philosophies discussed in this episode will hopefully help you expand your thought process and some of the things you consider when you're helping a unique person in pain. With that said, we'll leave it to the episode. Hope you enjoy. Welcome to the podcast, Peter.
I appreciate it. Yeah, thanks for the invite. Happy to be here.
Yeah, I've been a fan of your work. I've read a bunch of your work. We've had you and Catherine Harmon on our academy when we did a masterclass around some of your papers around enactivism, and really enjoyed it at that time. And I'm excited to have you on the podcast by yourself to discuss some of the work you've had recently. Pretty busy on the research front. We'll talk to that a bit. But I'm wondering, Peter, for those of the audience who aren't maybe familiar with you, if you could introduce yourself, maybe go over a little bit of your journey to where you're at today.
Yeah, for sure. So my name's Peter Stillwell. I'm currently a postdoc researcher at McGill University in Canada. I have a bit of a eclectic background. So I started out doing an undergraduate degree in kinesiology, so anatomy, biomechanics, that type of stuff. Did that at University of Calgary in Canada. Then I moved east to Toronto, did a doctor of chiropractic. And then I started practicing as a chiropractor. Then further even east in Nova Scotia in Halifax. In my first week in practice, I started doing a research master's in rehabilitation research in physiotherapy at Dalhousie University. And then didn't suffer enough through the research, so decided to do a PhD in health. So for a long time, I was trying to do it all. I was like, I'll practice clinically, I'll teach, I'll also do research. And then I quickly realized that's really challenging. So I was turning down a lot of research opportunities, collaborations, just because it was so busy. And so I was like, I'll take a year off clinical practice just to take on some more research opportunities. And that 1 year now turned into multiple years. So right now, primarily doing research and educational type of stuff.
Yeah. And pushing out some research, which again, we'll link a bit of that in the show notes as far as Peter's work with his colleagues and his research teams. One thing that I wanted to discuss, and then we're going to get into some of the kind of work you've done recently, is actually some commentary on the work you did recently. And I think it hits home to some of the challenges as like a clinician who's trying to figure out where does this stuff all fit in the clinic. There was a tweet from Adam Meekins, and I've also had interactions on Twitter and seen some good discussions around from David Poulter and others around some of the terminology and philosophy and things. Man, it seems pretty heady and ontology, epistemology, and dispositionalism and all these things. But it leaves a clinician kind of scratching their head and like, well, how does that help me with the person who's sitting in front of me that day. But there's obviously a good place for the work that you're doing, and it helps inform practice. Obviously, the whole point of this podcast, and hopefully what's going to happen today, is we'll help translate a little bit of that. Okay, this is where this may fit with the clinical piece. I'll hopefully weave that in along with Peter and his experience. I'm just wondering if you can speak to that a little bit about kind of that challenge that exists with, writing in an academic research setting and then having clinicians trying to, take this information and see where it fits.
Yeah, for sure. So I guess as a starting point, a lot of these papers they're academic papers, like you mentioned. So they rely on specific terms, specific concepts, and we do our best to define that in these papers. And so I kind of view these things more as like these papers as more of like an academic foundation, and so primarily target people that are already interested in theory, interested in exploring these concepts and applying them in different ways. And then what we can do is then take that academic foundation and then translate it and adapt it to different audiences. So clinicians that maybe aren't so interested in theory, people living with pain, those types of groups. So these papers on their own are often quite difficult to access, especially if you're not familiar with phenomenology, so the study of experience, different strands of philosophy, enactivism, ecological psychology. So it can be quite challenging to navigate at first. So I view this stuff like you would view like learning anatomy or physiology. These things are all taught to the health professionals. And you're learning about complex processes, these really challenging concepts. And it takes a lot of time to learn that type of stuff. And you're not relaying all that to patients, but it's just providing a foundation that you can kind of build on. And unfortunately, though, we're not really taught a lot, at least in North America, a lot of philosophy, a lot of this type of stuff. So I think a lot of the words and terminology can seem quite foreign and can be quite confusing. You look at an abstract and you're like, what are all these terms? And rightly so. So we do our best to unpack some of those for people that are interested in theory. And then we have future initiatives that we're planning to translate this type of work to relevant audiences. So I guess another point too is like, I think this philosophy is quite challenging to navigate, but extremely important. So we all have, if we're talking about pain, we're on the Modern Pain podcast. So if we're talking about pain, everybody has a philosophy or working understanding of pain, whether they realize it or not, and whether they put a label on this or not. So some of these papers is getting people to be more explicit about their philosophical understandings of pain, to be more reflective of what type of models and frameworks they may be using or may not be using. And I think that has important implications for research and also practice. So you think of like different frameworks that people kind of work within, either implicitly or explicitly. So historically, we had a strong, what philosophers will often call like a positivist approach. So viewing pain in a very kind of like objective, scientific type of paradigm. And so there's been a strong focus within that paradigm to just kind of look into the brain tissue, look into the physiology, and that's where we're going to find the essence of pain. Whereas with other philosophical paradigms, constructivism, for example, enactivism, people say, wait a minute, pain is a subjective experience, a personal experience. We can't see it or directly observe it by looking into the tissues. The best tools we have are to listen to that person's narrative. They'll tell us whether they're experiencing pain or not. And that type of approach is more in line with a constructivist kind of paradigm. So I think there is important implications in terms of the paradigms, the philosophical assumptions, the frameworks that we use. And a lot of our work is to kind of get people thinking about that type of stuff.
No, you bring up some good points. I fully agree with you that like philosophy was nothing that was even discussed. I remember I took it in undergraduate school and university, and that was the first real dance I've had with it. I really enjoyed that class because it was a lot of open debate with folks on some interesting philosophical topics that existed out there. And through yourself and Matt Lowe and Cause Health and a lot of others, it's really helped me. I did a great course on the philosophy of science, which I'd highly recommend if you get a chance to, because it really helps you kind of step back from your world and take a 10,000 foot view of how you're viewing your world. Not even maybe just clinically. It obviously skews towards more science, but of like where your worldview is and what you consider like valid ways of acquiring knowledge, and what do we know, and what's behind the experience, like you said, phenomenology. Do we have to get super deep and take PhD dives on it? No, but I think it is helpful, like you said, Peter, to kind of understand some of these implicit assumptions we operate under that we don't even recognize half the time. It was just helpful to me to say, gosh, I really look and treat pain based on this just assumption that it is true, that I should be able to identify it in the tissues, find the dysfunction, fix the dysfunction, and pain should go away. This linear, kind of more biomedical view of pain that we obviously know is very limited, has its moments where it can be very helpful, that there's some amazing disease processes that a biomedical approach has really, if not eradicated, greatly helped our ability to help people with. So it has its place, but definitely its limitations. With that said, then came on the biopsychosocial model of Engel in the 70s, and a lot of your work has talked to maybe some of the limits and how we've been applying it, and still maybe looking at it still in a very piecemeal, categorized, kind of siloed approach of the biologic, the psychologic, and the social components of a pain experience. Yet all those variables are interplayed, and we'll go into your 3 E's of kind of how that kind of sits in that. But I'm wondering if you can kind of speak to some of the issues your work's been trying to address as far as the applications of the biopsychosocial model.
Yeah, for sure. So I don't get me wrong, the biopsychosocial model was a huge advancement. So I think sometimes people will just read like the titles of some of the papers, and it's like beyond the biopsychosocial model, and they're like, oh no, like I just learned about the biopsychosocial model, now I got to toss it out and learn something new. And that's definitely not what we're saying. We're more saying that we can kind of build on the biopsychosocial model and add some theory to it. So some of the issues that we've written about is like the biopsychosocial model as Engel proposed it was very vague in terms of its theoretical foundation. There wasn't a lot of details there. So if you look at like the landmark paper in 1977, some of the papers after that in the 80s, he essentially said, hey, here's the foundation, the theoretical foundation. All these different systems are just like linked somehow. So like biopsychosocial type of systems, and information kind of flows somehow across those systems. So he proposed, like, for example, one of the papers in the 80s, like this hierarchy of like systems. So like ranging from like the kind of like social environment to the person, down to like organs, down to cells. But it didn't really say how all these things are connected. But it did help us appreciate, if we're applying these things to like pain, okay, well, we need to consider more than just the biology. But it didn't really get us closer to understanding what that subjective experience of pain is like. So what it's like to live with pain, especially chronic pain. And it didn't really give us an explicit framework or theory for how these different biopsychosocial factors relate to each other. So is one more important than others? Is one at kind of the foundation, or they're built on it? There wasn't actually good information about that. And so that's where some of the theory that we've been engaging with comes into play. It can help us unpack some of those questions that we had, fill in some kind of theoretical gaps that Engel left us with, and can help us better understand the experience, the subjective experience of pain. So theory can offer a way forward in that sense.
Yeah, definitely. I mean, as you said, it was a huge advancement, and I agree. Some folks are like, oh my God, don't tell me what I just was transitioning from the biomedical to biopsychosocial. Now you're telling me I got to freaking throw that away. No, it's just as science, a healthy scientific world does, it develops and it builds on to things of the past. And even biopsychosocial built off of the biomedical model. And I mean, it didn't say throw the biomedical model out. It just said, hey, definitely limitations. We need to expand our thinking. But then again, as you've pointed out, we got maybe some things we need to think about as we're trying to figure out where this whole BPS model fits. I'm wondering if you can discuss a little bit about the 3 E's that you speak of. Maybe we can take one by one. As far as the first one, and the 3 E's just kind of the approach as far as and how we kind of look at humans in pain. And first one being embodied, that it's an embodied experience where this painful experience is, environment, social world, biological world, psychological world is embodied into the person. I'm wondering if you can speak to that a little bit as far as kind of how you look at that in your model.
Yeah, for sure. So I guess as like a starting point, so there's a ton of different theory on like what's called like 4E cognition. So the idea that experience is embodied, embedded, enactive, extended. So this isn't like words that we've created or anything. It's built on a long history. It's built on over a century of theory, and there's whole textbooks dedicated to this. Tons of different papers dedicated to this. So, for example, the 4E or the Oxford Handbook of 4E Cognition, a huge, massive textbook unpacking the nuances of these E's. But like in really kind of like simple terms, if we're talking about embodiment, we're talking about how experience or cognition is embodied. The idea is that we experience the world and we experience ourselves with and through and because of our bodies. So not just focused in on the brain, we're focused on the whole person, including their narratives, their past history, their concerns, their expectations. The next E, embedded, essentially, once again, kind of a complex history, but the idea is that we're always embedded in an environment, and that environment is both physical and social, and that shapes how we experience ourselves, shapes how we experience the world. And I think that's quite intuitive when it comes to pain. So lots of empirical work substantiating that the context, the environment shapes our experience. And the third E that if we're talking about 3Es is experiences enacted. So, or the word sometimes is inaction or the enactive approach. And as the name suggests, it focuses on action. So the idea is that experience is generated or enacted or brought forth through our interaction, our dynamic interaction in the environment that we're in. So essentially, if we bring all these kind of E's together, it gives us a kind of like comprehensive picture. So if we're trying to better understand experiences like pain, we can't only look into the brain or only look into the nervous system. That stuff's important, but we also need to zoom out a bit, look at that whole person, listen to their narratives, zoom out even further though, and look at the environment that person's in. And I think what's attractive to me is like, if we're taking this type of theory quite seriously, it pushes back a lot on what I think has historically been a very kind of reductionist and individualistic approach to pain. So by reductionist and individualistic, I mean only focusing on the individual or only focusing on the individual's parts, so their brain, their nervous system, instead of taking a more kind of comprehensive approach. So I think it forces us to look at, yes, the person, the characteristics of the person, but also in relation to their environment. And I think historically we've neglected a lot of those environmental, those social features that have contributed to or are potentially sustaining pain. So I think, for example, like the culture of pain, like, oh, it's very kind of like in the tissues. There's some sort of tissue-based explanation, and largely kind of overlooking the messages that we're giving patients with that. So the idea that increased damage equals increased pain. And then we see people are fearful. We see they're apprehensive of exercise. And it's no wonder with the cultural messages that we're giving them. And then unfortunately, a lot of clinicians are then blaming these patients and saying, well, it's because of your fear or because of your brain or your nervous system. And we're overlooking or minimizing the role that we're kind of playing, the culture is playing in contributing to that situation. So we can run into issues where we end up blaming the person where I don't think we really should be. So that's my rant for the day.
No, and I enjoyed it, of course. But you bring up some good points around, we see all these things embodied and enact, with somebody's social setting and how they're embedded in this social setting, that we sometimes, when they're stepping into our four walls of our clinic, it's the four walls of our clinic where we're going to interrogate their tissues and their symptom behavior, kind of isolated in a very, and I know we give research studies, a lot of these randomized control, because it's this false setting of these very tightly controlled variables. Well, our clinical settings are kind of similar as far as that's not where the person's embedded. Like I always tell patients, like I can often make you feel better in these four walls because there's a lot of good things happening in this context. You got the most rah therapist on your side who's gonna do some things. I can do some manual therapy things that might make you feel better a bit, but where I want you to feel better and move better is when you are playing with your grandkids or whatever valued goal that the person says. So having a good grip on what's the world that person inhabits outside of your clinic can be so huge. And sometimes, I mean, it can be frustrating, depressing, emotional when you hear some of the stories of what worlds people are functioning in. And yet we think we're sometimes, and I know I was naive to think that I'm going to just step into this narrative in this person's world and just make a 180 in their pain because I'm this amazing hero clinician who's going to fix it. Yet I've had to come to terms with the fact that there are just some patients that function in worlds that are not conducive to, a healthy human, be it pain-wise and everything in between. So I think having these approaches and thinking of how somebody's embedded in their world can be so huge. Definitely not to say there aren't people where we can help them better navigate their unique context and unique environments. I don't want you to think that, we just give up or anything like that, but hopefully helping people understand that this cultural narrative around pain that you speak of that can be ridiculous and, has clinicians like myself early in my career just putting people in these movement jails. And
me too. Yeah.
Yeah. I think we all can probably have a support group of all the bad things we did with, not knowingly bad at the time, of course, but when we just limitedly, just apply things very much without these thoughts in our mind as far as having a good conception of these things, I think your research and a lot of the philosophical stuff that's come out has really helped us better understand that, to make, clinical life not as frustrating, because then again, like you said, we just end up going in the back room and blaming the patient. It's their fault. It's they're fearful, or they're a malingerer, or they're a symptom magnifier, or whatever things that we throw at patients when it's a complex situation that makes us feel inferior, imposter syndrome. It's kind of, I think, just a defensive mechanism for a lot of clinicians just to go. And I've been there with, where we, talk in back rooms about the difficult patient and things like that. I don't thankfully do that anymore. But one thing I wanted to speak to a bit with you, because you've kind of proposed some thoughts with some of your colleagues about the field of affordances and how that may be a helpful way to kind of give us a kind of a framework or a thought process to start navigating, what options are there for actions, and how does that field of affordances change when somebody has been in pain? Maybe you can speak to that, and then maybe we'll get into a bit about how we can use those field of affordances and that thought process to maybe move somebody into a better direction.
Yeah, for sure. I guess it goes back to like these enactive kind of concepts. Enactivists often focus on all these kind of interconnected concepts that start with E's and start with A's. And one of the ones that starts with A's is affordances that enactivists rely on. And I touched on affordances a bit in my 2019 paper, but others have led more expansive work, really unpacking this concept in relation to pain. So Dr. Sabrina Konings, Dr. Daniela Vaz. So they've led a lot of work on affordances in relation to pain, but I can maybe briefly touch on it. So the concept stems from ecological psychology, so J.J. Gibson. So it's not a term that we've created. There's a rich theoretical foundation. It's a well-established term in the cognitive sciences, in a variety of different fields and domains. And essentially the idea is that affordances are perceived action opportunities. And in the papers, we kind of highlight how there's this view that affordances are relational. So it's a relation between a person with a unique history, concerns, expectations, a certain type of body, and the relation between the physical environment and social environment. So a simple example is a chair. So to humans with certain types of anatomy, certain types of mechanics, certain types of social conventions, we perceive a chair as something to sit on. But other organisms, so a snake, other type of animal with different anatomy, they don't perceive the world in that way. So that's kind of a simple example. But the idea is that our affordances change as we experience pain. So action opportunities will often shrink or diminish. Certain things that were attractive in the past may be avoided. So maybe if you have certain types of back pain, sitting on a chair is no longer perceived as an option for you. And I guess what I like about this concept of affordances is it is very kind of like forces us to take a comprehensive approach to considering the patient and the relation with the environment. So we have to consider the patient characteristics, we have to consider the environment and the specific relation between the two. And we have to appreciate that each person's affordances are unique. So we may actually look at a person and do some sort of examination. We're like, oh, you could totally go and sit on this chair. You're physically capable to do that. But to them, from their personal perspective, their history, they don't perceive it in that way. So I think it helps us avoid some of the siloing that we see with like the biopsychosocial model, where it's like, okay, here's a bucket of biological factors. Here's a bucket of social factors. It's a more dynamic concept, a tricky concept to force us to consider both sides and the relation between the two. But I think that's not typically how we think. And so it's a really tricky concept. So I was watching a podcast the other day, two famous philosophers, one that works in the area of affordances and another that hasn't really engaged in depth with that concept. They talked for like 3 hours about affordances. And then at the end, the one philosopher is like, I still have no idea what this concept means. And I think it's just such a tricky concept to wrap our heads around. But once we do, I think it can help us avoid some of the pitfalls that we have seen with, for example, the biopsychosocial model. So that's just some thoughts off the top of my head. I don't know how coherent it is, but
no, I think affordances, and I've seen it defined in some papers, just like opportunities for action within an environment, where, and I just think, I thought back to my, my early career when I was reading some of the stuff. I'm like, man, I stripped a lot of affordances away from people, from getting them scared of like, oh, you got to move with a perfect braced spine, or you have to, really be paying attention to don't let your neck go forward over your shoulders. And all of a sudden, and probably telling people, I mean, there's a whole industries built around the right pillow or the right bed or the right chair or all these things. And I have a patient right now where she's been working with an osteopathic narrative, a very traditional one of alignment, where everything has to be perfectly aligned for that person to be functioning well in the world. And if there's pain, then something's malaligned, and she needs to really be careful till the practitioner of choice decides to put things back in alignment. So her affordances have been very much, she's now shrunk down to where I try to avoid stairs because I don't want my pelvis to be one leg in front of the other. She gets in the car where she sits with both legs swinging at the same time. She's just really shrunk down. And again, of course, this wasn't something that the osteopathic provider was purposely like, let me just really limit this person's life. But when we operate on some very dated, I guess we could say, theoretical constructs of pain, and people really buy into it very seriously, it can really... And I've reflected back, and then what I always say is, like, I've put people in movement jail regularly in my past because of this conception of pain I had, that there were proper movements and improper movements, and if you did the improper movements, you were going to get pain. And now, obviously we've expanded that. I would argue more of my work is just working in that field of affordances, and just kind of, as a lot of your work in the papers with Konix and other colleagues of yours talk about, like, just expanding that field of affordances, co-creating a narrative with somebody where you understand their embeddedness. What are they embodying? Well, it's their world that they're embedded in, and their past experiences and all that narrative stuff that helps inform all those 3 E's and different things, and see what kind of affordances we can start helping the person be open to and willing to start up working with. But then again, it goes into there's fear. Well, you better be able to pull out some CFT, exposure-based, experiential learning-based strategies to help people expose themselves to maybe these affordances are there if you are open to exploring them a little bit. Does that kind of ring true with kind of how I know, like you mentioned, you may not be in the clinic, but you've been in the clinic, you've seen your share of patients in the past, and I know your work is try to help us on the front lines when we're working with people, but does that kind of ring true with what your kind of thoughts are on the kind of model and theory behind things?
Exactly. I think you really eloquently kind of outlined some of the clinical implications of this theory. So I think a lot of times clinicians unintentionally shut down affordances or action possibilities unnecessarily. So through the words that we give, the descriptions of pain, explanations of pain. So we wrote a paper, I think it was 2021. It's in BMJ's Medical Humanities. So it's called Painful Metaphors. So it's a bit of a theoretical paper. It's also got some empirical work in that as well. And what we argue is a lot of clinicians are unnecessarily shutting down patients' action opportunities, moving them away from the activities that used to be really meaningful to them, that they really enjoyed. And it's not that they're doing this intentionally, it's unintentional because they haven't considered the kind of philosophical framework that they're working in, the implication of the language that they're delivering. And so once again, we argue that being more reflective of the frameworks we're working in, our understandings of pain, can help us move towards opening up affordances when safe to do so. So I think we have to put a caveat there because sometimes it is important to close down action opportunities. So an acute fracture, for example, we're not going to be like, yes, let's totally open it up. So I think we got to be quite diligent and intentional with how we're opening up or closing down action opportunities. And what I like about this concept of affordances is it takes, I think it's what's in common with a variety of different therapeutic interventions that have historically been separated. So CBT, like exposure-based therapies, pharmaceuticals, manual therapy, exercise, a commonality across all of these is we're ultimately trying to move a person towards their meaningful action opportunities, meaningful engagement with things that they enjoy. And so we can actually open affordances through a variety of different means, intervening at the level of the individual, intervening at the level of the environment, for example. So a lot of enactivists are interested in what's maybe even don't even focus on the individual, but change the physical and social environment to then change how a person then experiences themselves and their world. So there's kind of some funny examples of this. There was an enactivist art installation where they actually made a room where you physically couldn't sit. So instead of changing a person's behavior, they actually made a room to just change that person's experience and behavior. So I think that's kind of like a funny example. Why we'd want to do that, I think is debatable, but there's other interventions like VR, for example, where it's a bit cheaper than creating a physical environment, where we can actually change how people experience their bodies in the world. And that can potentially open up affordances or action opportunities that wouldn't be available otherwise. And then how we can translate to the real world settings is a kind of an area of ongoing research, which I think is super interesting. Yeah.
Yeah, no, it is fascinating stuff. I think, like you mentioned, this kind of going from the micro within session, within individual, to the macro, like societal, systemic challenges and different things, socioeconomic challenges that some folks face, and giving people, hopefully working on social issues that can help people maybe better experience healthcare, better experience pain, better experience health in general, when definitely the Western diet here in the U.S., I'm sure similar, maybe not quite as bad in Canada, but I know
where I'm at right now in rural New Brunswick, it's pretty sketchy.
Yeah. So, I mean, I always tell people it is not easy to be a healthy person in our current culture and society. It's just, we have so many narratives and things thrown at us, advertising and things, that just makes it hard. And then, a biomedical machine that still is working, getting better slowly, never as fast as we'd like it to be, to just start, especially around pain, musculoskeletal and everything, and others, where we got to expand beyond just stripping people of affordances. And like you said, it's that the dance becomes clinically of when do we open up affordances? To me, it's like when somebody, it's like, the protect and versus expose, calm it down or build shit back up, as Greg Lemon would say. And that's that open up the affordances versus close them down. thought processes where the I guess the art of it to some extent, but that's again the ability as you as a clinician to look somebody in the eye, know where they're at from as much of their world that they're inhabiting, that they're embedded in, not just in the four walls of your clinic, but outside those walls. Know your biology and your biomechanics and your tissue pathology and physiology to know where they are in healing phases. Know some of the psychology things of fear avoidance and different things like that. It becomes, it's complex, but I think the more you can kind of bring these different things, which is why I've really gravitated towards your research, because it's kind of been where this whole pain science movement and things is going. It's like we need to, in the biopsychosocial model, we need to incorporate these things, but we don't really have good frameworks. Some of the things that I know your papers, the recent one with Vass, I'm terrible with first names, and Matt Lowe and yourself.
Daniela,
Daniela Vass, yes. It spoke to, mind maps and vector models. I'd encourage you, and we'll link that paper in the show notes for y'all to kind of think of that, because it can be somewhere to help some of this stuff have some clinical grounding to where maybe you can, use a mind map with a patient to show, one, all the complexities that exist in a pain experience. And there's a nice diagram in there about that. And then also the vector model. Matt Lowe had used that back, five, 6 years ago, I believe, in a journal article, and has it in there. And I've found those to be helpful just for people to get a visual of not this linear pathway of your MRI equals your pain experience, that they can start, as you start listening to their story and maybe putting stars or asterisks next to these things that they're talking, and then you can start co-constructing a narrative. Maybe you summarize it at the end. Peter O'Sullivan always does a masterful job of that when he was, watching him work with patients when he was at the Pain Summit in San Diego. Just unpacking all that, basically being a good attentive listener, a very purposely curious clinician, to gather as much of this stuff to understand the most he possibly could about the world that this person inhabited, the affordances that they have, and maybe the ones that are avoiding or stripping themselves away from themselves, and then, constructing a narrative with that patient. It's not easy, but man, it's so much. I find it fun and fascinating because, one, you never know. You got so many unique people that come in your door that you get to figure out what's that unique world that person functions in, what's the unique worldview they have of their symptoms, and what affordances have they stripped themselves away with. So hopefully our discussion today has helped you guys see how this stuff all can relate to some good work in the clinic, but not easy, because if pain was easy, and it just opens up that there's a lot of complexity with people that we need to be aware of in our clinical world. Peter, I was wondering if you could speak to where you think we need to go with some of this research, or where you're planning to go with your colleagues as far as to help. I know you spoke to maybe, having some ways to translate this to different populations, maybe more of a clinical population and maybe a patient population, so they can see this stuff. I'm just curious where you see things moving in the future.
Yeah, for sure. I guess to clarify too, a lot of this work is just off the side of my desk. It's not my main area of research. So the enactive stuff, ecological stuff, it's fun stuff that I do on the side. So it was part of my PhD work, but I largely moved into other areas of research, but I still find it fun to dabble in this area. But yeah, mostly what I've done in the past is just starting to lay out a theoretical foundation. So clinicians will often reach out to me. They're like, "Oh, I read this paper," and they're excited about it, whether it's the 2019 one or the new one with Dr. Sabrina Koenigs. And often I'm just like, "Oh, I'm sorry you read that." Just because it's and originally the intention wasn't for this stuff to be for clinicians. It wasn't targeted in that way. It was for people engaged in phenomenology, cognitive sciences. It was to build kind of an academic foundation. So the future work that we've kind of been moving towards is making this stuff, tailoring and adapting it for specific audiences. So they're everyday clinicians, people living with pain. So we recently got a grant to start doing some of that stuff. So that project will start in 2024, so next year. And the idea is to create some non-academic materials for non-academics. So whether that's a YouTube video or infographics, things that are a bit more accessible, because as we talked about earlier, these papers are very focused on engaging in the academic debates in this area, focusing on the specific concepts. And it's not as accessible as it could be. So we're fully aware of that. And so working to improve that and make it more accessible to other folks. And ultimately, the idea is to like hopefully reduce some of the misapplications that we see with the biopsychosocial model because of its a bit of a flimsy theoretical framework. So in some of our papers, we talk about the biomedicalization of the biopsychosocial model, how it's often fragmented, and how people will often say they're taking a biopsychosocial approach, but end up just placing an overemphasis on the brain or nervous system kind of tissue. And that stuff's important, but we also need to zoom out. So concepts like affordances help us do that, and help us do things with a bit more intention. So we're not falling into these traps that we see when we're relying on models or frameworks that are quite vague. So that's the kind of the general idea. Yeah.
Yeah, I think I speak for a lot of folks who are listening, to give you thanks for, the work you've done on it. You've definitely helped us gain some clarity, with some complex topics, of course, but you can see in some of the work you've done with your colleagues in affordances and enactivism has been, a helpful boost to kind of help us see that, we need to try to avoid just siloing ourselves into the next thing, be it the brain and nervous system. That became a very neurocentric way of looking at pain that, still we need to see that it exists in this big, world that a person's embedded and a lot of different things that we spoke to in the podcast. So really appreciate your work. I'd love, you got some big plans coming up. You're going to be changing continents last I heard. So you mind sharing what you're up to?
Yeah, for sure. So I'm still working at McGill, but I'll be transitioning. My new primary affiliation will be University of Southern Denmark, starting in the new year in March. So moving to Denmark, and I spent a bit of time there last year. And so essentially working in a department that has people in the rehab professions, but also philosophers, very, very unique kind of environment. And I kind of straddle both worlds. I engage in philosophy, cognitive sciences, phenomenology, but also try to anchor it somewhat into clinical practice. So this will be an opportunity to kind of work with both groups. And I'm excited about that. So I'll be there for 2 years. Yeah.
Well, I'm excited to see what comes of it. I'm sure you'll have some good thoughts stimulated and some good research that comes out of that experience. It seems like overseas is just a little bit more kind of into that more ability to explore those topics, the ability to have some of those opportunities. So great for you. Hope it's a great experience. And thank you for your time today. Really appreciate it. And we'll hope to talk to you soon.
Sounds great. Yeah, I appreciate it. Thanks a lot.